Hello, I'm Dr. Amy McLean, Chair and Professor in the UAB Department of Physical Medicine and Rehabilitation. I also enjoy a practice serving individuals with spinal cord injuries. Often I am asked about the issues concerning women with disabilities who wish to become pregnant. Women with all levels of spinal cord injury should have the option to have children if they choose. Like all women, however, they'll require medical professionals to prepare and guide them through pregnancy, labor, and delivery. Unfortunately, there's a paucity of information for professionals on managing the potential challenges that women with spinal cord injury face. In this video, you'll hear from an obstetrician who has not had specific training for women with spinal cord injury who are pregnant. Nonetheless, he successfully managed one woman's journey through 2 pregnancies. You'll hear from that mother who will share her pregnancy experiences as a woman with a spinal cord injury. You'll also learn from various professionals in the field of physiatry, nursing, and occupational therapy. They'll offer guidance on the value of a team approach in identifying and dealing with the challenges these women have throughout the pregnancy continuum. This video is to offer a guide for professionals who encounter women with spinal cord injury who have concerns about having safe and successful pregnancies. You, as a healthcare provider, should be able to give information that allows them to make an informed choice about pregnancy and parenting options. Furthermore, you will become knowledgeable about the many unique pregnancy and SCI-related issues important for counseling and educating your patients with spinal cord injury who are considering or who have already become pregnant. Most obstetricians have few opportunities to manage women with spinal cord injury who become pregnant. A team approach is essential when caring for these patients. For example, consulting a spinal cord injury rehabilitation specialist, called a physiatrist, is valuable. As a physiatrist, I like to follow these women at least once a trimester to monitor spinal cord injury related problems that may arise. Other specialists who are important on the team may also include urologist, anesthesiologist, pulmonologist, wound care practitioners, physical therapists, occupational therapists, or others.
Just as most women with spinal cord injury naturally think about having children. Their first question is usually, can I get pregnant? As a nurse who works with women with spinal cord injuries, I feel that it is my role to be a facilitator between the woman and her healthcare team. That often can involve anything from just a simple conversation with the patient to a referral to the appropriate discipline. I want to be an advocate for her.
In many ways, preparing women with spinal cord injury for pregnancy is similar for all women. However, there are unique aspects that are different. A thorough medication review is necessary. Many prescriptions and over-the-counter medications taken by women with spinal cord injury should not be taken during pregnancy. Healthcare providers should review the current genitourinary baseline, as women with spinal cord injury usually have a neurogenic bladder.
There are not many resources for women with disabilities to read about pregnancy and parenting. I desperately wanted to be a mother, but it took me a while to decide to have my first child. I had concerns like most first-time mothers, like would I be a good mom? My concerns were deeper though, like will my physical limitations prevent me from being the kind of mom I dream of being? I simply didn't know how I would be able to do all the physical tasks of taking care of a baby and a toddler. I also had concerns about pregnancy and delivery. I thought I would probably need help with transfers and positioning later in pregnancy, but that didn't bother me much. I was more concerned about being able to do my bladder and bowel programs independently. I read how some women have bladder accidents more often, so that was a concern because I do intermittent catheterizations. I wanted to avoid a C-section if possible because I've had a bladder augmentation and didn't want anything to cause a problem with that.
I had a unique relationship with Whitney in that I'd known her dad, Whitney, her family, for years prior to even before she had had her spinal cord injury. And in taking care of her, I knew that a family was part of her plan. It was with a bit of trepidation that I was wanting to take care of, because it was something I had no experience taking care of someone with such an injury. It made it a little bit, made it quite a bit easier knowing that I had a motivated patient who took such good care of herself, and I knew that she would do whatever we asked her to do during the pregnancy. Well, in Whitney's case, we knew that we had a physical difficulty, but nothing that from her injury that would impair or impede her being able to get pregnant. So we go through her family history, genetic history, her particular medical history. Are there any medications that you're on now, Whitney, that we do not want you to be taking while you're pregnant?
Women with a spinal cord injury usually know their risk for secondary medical complications related to their spinal cord injury and how to manage them. But they should be advised that their risk for developing some secondary complications increase as their pregnancies progress. For example, there's a greater incidence of urinary tract infections, pressure ulcers, autonomic dysreflexia, and their bowel program, just to name a few.
It's impossible to predict when or if secondary complications will develop. Some may occur early in pregnancy and go away in time. Others may continue to be a problem throughout pregnancy and delivery. The most common problems to look for in the first trimester are autonomic dysreflexia, along with issues related to bladder and bowel management. There should be a plan to prevent or manage these problems as needed.
I didn't notice any major changes during the first trimester of my first pregnancy, but the one thing that stands out is I almost fainted. The fainting spell only happened one time, but that's how I knew I was pregnant. I was also extremely tired, like most women.
Obviously, during the first trimester, one always has the concern, potential for a spontaneous pregnancy loss. But other than that, no concerns. At your initial prenatal visit, we would want to go ahead and do a urine culture along with the other prenatal labs, trying to decide what are we going to do to decrease the risk of urinary tract infections. If her culture is negative, that's something that I think is probably going to be followed about every 2 months along with the routine urinalysis. If she has a positive urine culture in the first trimester, especially if we are doing self-catheterization, I think I would even consider at that point going ahead and putting her on a suppressive urinary tract antibiotic. Most times we'll utilize macrobid for that. During the first trimester with an initial OB visit, we also will do an ultrasound. Even though she knows when her last menstrual period is, the most exact dating I can have of the pregnancy, very important, is with a first trimester ultrasound. So we will do a follow-up growth ultrasound at 18 to 20 weeks of pregnancy, and assuming all of our lab works, our antenatal testing have been normal, growth ultrasound looks good, then second trimester is pretty much going to be uneventful.
Obviously, the growing fetus puts more pressure on the bladder, which may decrease bladder volumes and increase bladder spasms. For women that are continent, they may begin to experience spasm and leakage that they've never had to manage before. And women who use intermittent catheterization will likely need to catheterize more often or possibly switch to an indwelling catheter during the later phase of their pregnancy. This is not permanent, and it may simply be just because of the change in their body habitus.
Pressure ulcers are always a concern for women with spinal cord injury, but weight gain can change posture and center of gravity, which puts added pressure on bony areas when sitting or lying down. This creates an increased risk for developing a pressure ulcer as the pregnancy progresses. Women should be advised to increase frequency of skin checks and weight shifts, and obstetricians should include skin inspections as part of prenatal exams. It can also be helpful to consult a physical or occupational therapist to evaluate durable medical equipment and seating to reduce pressure sore risks.
Women typically start to experience noticeable weight gain during their second trimester. For women with spinal cord injury, the continued weight gain can lead to a number of issues related to fatigue, mobility, and management of daily activities. In most cases, there are solutions to managing these problem issues. A physical therapist can be consulted to solve problems with mobility, like if there are issues with transfers, positioning, and wheelchair use. An occupational therapist can be consulted for issues of daily activities, like with dressing and bowel and bladder management.
I had much more energy during the second trimester of both my pregnancies, but I had extreme dizziness, and I could tell a spell was about to happen. I would start to yawn uncontrollably and would have a few minutes to get to a safe area before I would begin to see spots, hear strange sounds, and feel a bit numb. It usually would only happen for a few minutes. Dr. Pearson thought it might be happening when the weight of the baby was restricting my blood flow. I now know that dizzy spells happen to women without disabilities too, but I did not know this at that time.
During the second trimester, as the weight of the uterus with the baby, placenta, amniotic fluid are increasing, there are times, especially when you're more often in a sitting or even supine position, the weight of the uterus may cause a little vena cava compression. By doing that, it decreases return flow to the heart, may decrease the cardiac output, may cause just a postural type of dizziness. Usually by changing position, perhaps even just pushing the uterus to one side or another, may be able to alleviate that. During the second trimester, there are some antenatal blood tests that are done, specifically looking increased risk of chromosomal abnormalities or for neural tube defect. Those were taken. She passed those with flying colors.
Pressure from the growing baby often reduces circulation, leading to edema in the legs and the feet. It may be necessary for women to elevate their feet as much as possible, use compression hose, and get extra rest. Women may also benefit from consulting a physical or occupational therapist to improve circulation through range of motion exercises or changes in positioning. Currently, no evidence exists to support universal use of anticoagulation in these women. A heightened surveillance is more important, especially if the woman has had a previous deep venous thrombosis. Women with spinal cord injury, especially those with tetraplegia, may experience decreasing respiratory function due to restriction of diaphragm movement from the growing fetus. Deep breathing and coughing becomes more difficult. Respiratory function should be evaluated, and a pulmonologist or respiratory therapist should be consulted as needed.
My dizzy spells continued during the third trimester of both pregnancies. I had to catheterize myself more often to prevent leakage. I had heartburn pretty bad as well. I also began to use a sliding board for transfers and had people help me with transfers whenever I wasn't alone. I needed help turning in bed as well. I had shortness of breath where I would have to really concentrate to breathe at times. My legs were swollen and I had to elevate them as much as possible. During the end of my second pregnancy, I had a urinary tract infection that was hard to get rid of. Dr. Pearson ended up having me go to the hospital for IV antibiotics a few days before I was induced. My second pregnancy was different because I had a broken leg. Transfers and mobility were really hard. I couldn't drive for months. Honestly, after I recovered from the fractures, the pregnancy seemed like a walk in the park.
Fetal surveillance is going to be something that we'll do more so in the third trimester. Even if we don't find any risk factors particular to this pregnancy, such as hypertension, intrauterine growth restriction, decreased amniotic fluid, there does need to be an increased or heightened sense of awareness of fetal surveillance. So at about 30, certainly no later than 32 weeks, beginning weekly non-stress tests and or biophysical profiles would be appropriate. And if there is a medical problem in addition to the injury, this may need to be bi-weekly. Another concern we have during the third trimester is premature labor. Many patients that have had a spinal cord injury may not have any sensation of any contractions or pressure or any other type of pain that lets them know that they are having labor. So to try to preclude that being a problem, options are you can do ultrasonographic measurements of the cervix, making sure that it's not shortening, which it is going to do prior to dilating, checking the level of the baby's head at that time. Manual physical exams can be done at the same time. So usually I would say with Whitney, at 28 weeks, maybe we'll check a cervical length ultrasonographically. 30 weeks, we might do a bimanual exam. 32 weeks, do another ultrasonographic cervical length. Then starting around 34 to 36 weeks, depending on the findings, then we'll start weekly examinations, deciding, number one, let's make sure we don't go into preterm labor. Number two, when can we schedule a term induction of labor?
Women with spinal cord injury need to plan for labor and delivery in the same way that other women do. They should attend childbirth classes, get the nursery ready, get the car seat and know how to install it properly, pack a labor bag for the hospital, and stock up on those diapers and wipes, and any other essentials that they may need. Women should also be advised to take a tour of the hospital, to see the patient's room, and ensure accessibility. The nurses and other hospital staff should be briefed on potential problems and issues, especially autonomic dysreflexia, and how to manage potential problems that may arise.
Detecting signs of labor can be complex. Some women with spinal cord injury may experience the same common signs of labor as other women experience. It's also important to educate women on other methods for detecting signs of labor. Women with injuries at T10 and above may not feel labor pain, but they can be taught to check for labor by feeling the uterus. Changes in breathing or spasticity may also indicate labor. Obstetricians can also begin checking the cervix weekly, beginning at 28 weeks, to watch for signs of labor. Use of a home contraction monitor is an option for women if needed, but a monitor should be used by all women with tetraplegia.
I saw Dr. McLean twice during each of my pregnancies, and she and Dr. Pearson spoke a few times to prepare for my delivery. Dr. Pearson's plan was for me to be induced so that he could be present for the delivery. Dr. McLean wanted to be sure I had a plan for autonomic dysreflexia, so we planned to have an epidural during labor and delivery. I did tour the labor and delivery rooms and spoke with the nursing staff, and they were wonderful and well informed even about autonomic dysreflexia.
During the labor and delivery process, you're not going to be using your medical anticoagulant medications because there could be an increased risk of bleeding during the delivery itself. We did use sequential compression devices during labor and then during the immediate postpartum phase to try to decrease that risk of blood clot formation.
During labor and delivery, it's essential to continue monitoring issues with autonomic dysreflexia, bowel management, bladder management, skin, spasticity, respiratory function, and circulation. Although autonomic dysreflexia is more common for people with injuries at T6 and above, it can occur in women with any level of injury during labor and delivery. Use of continuous epidural anesthesia is generally recommended for prevention or treatment.
Honestly, I was very surprised by how smoothly both my deliveries went. With my first child, I was given medicine to ripen my cervix and was induced. Oftentimes, my body does not work like it's normally supposed to do because of my spinal cord injury. But during pregnancy and delivery, my body did what it was supposed to do. Even though I'm paralyzed, Dr. Pearson told me when I tried to push, it helped to move the baby down. A few days after being home from the hospital after having my first baby, I ended up with a pressure ulcer on my tailbone that I battled off and on for a year. I think it started during labor and delivery, and the fact that I lost weight after my pregnancy made it harder to heal and stay healed. With my second baby, the delivery was much longer. I think because I didn't get the medicine to ripen my cervix. I was in labor for over 17 hours, then I dilated very quickly. And by the time the doctor came to check on me, my son's head was already out. I I knew something was happening, but I thought it was just another hard contraction.
With Whitney, when she got to be 38 weeks pregnant, we decided that it was time to induce her labor. We admitted her and gave her a cervical Reichmann agent, Cytotec, the night before, and then followed up with inducing labor with Pitocin the following morning. To make sure that she did not have excessive pain reflexes, we did give the epidural at an early time. I think she was only 2 centimeters dilated, so before she was in active labor, she had the epidural to try to control that. Unfortunately, we had a problem with our Foley catheter during her labor process, which did trigger some signs of AD, but once our nurses discovered that the Foley had become obstructed, a distended bladder was causing pain impulses that caused AD. Once that was identified, we corrected it and her symptoms did subside at that time. Labor process, just as with anybody else, continued her Pitocin stimulation until she was complete. She gave, I think, really very good for her, pushing efforts during the second stage of labor, able to deliver vaginally without a problem. So her labor and delivery process went as smoothly as I thought it could have.
Dizziness is not uncommon shortly after delivery. Women may need to sit up slowly, wear elastic hose, or use an abdominal binder to manage dizziness. And if an episiotomy is required, a heat lamp is not recommended due to sensory limitations.
Most women with spinal cord injury can breastfeed, but there may be a problem or issues. Women without nipple sensation may produce less milk. Breastfeeding can also increase bladder spasms, but most importantly, can also stimulate autonomic dysreflexia.
Again, there are solutions to managing most problem issues new moms face after delivery. In fact, there's continued growth in the development of adaptive options to make it easier for infant care. For example, there are adaptive carriers, strollers, adaptive cribs, elevated baby baths, and so much more.
My advice to any other obstetrician who is considering to take care of an obstetric patient with a spinal cord injury, number one, you have to know your patient and know what your patient's motivation level is and how much that patient is willing to do what your care for them says they should be doing. Combine that with their spinal cord injury physician, knowing what's going on there, what medications, physical activity levels that are available, and are there any particular medical concerns that physician has.
Despite all my worries and insecurities about becoming a mom, being a parent with my husband is the most rewarding thing in my life. The love and immense joy parenting brings overshadows the exhaustion and frustration that comes with it. I look at my children and see 2 miracles, and I'm so grateful to have them in my life. I learn from my kids every day about love and life and dreams. Like most parents, I'm always looking to become a better person, a better parent, but it's not because I have a disability. I want to improve and grow because I'm human.
The obstetric care of women with spinal cord injuries requires one to understand the interactions of the disability and the pregnancy. Not all women with spinal cord injury will develop significant complications, but knowledge of each patient's unique situation, coupled with close observation, will allow pregnancy-related difficulties to be recognized early and be treated or accommodated. As this population grows, a collaborative approach must develop among physiatrists, obstetricians, gynecologists, urologists, gastroenterologists, family practitioners, nurses, physical and occupational therapists, and any other healthcare practitioner. It's imperative that the medical team listens closely to their patients, as they are usually very knowledgeable about their bodies and quite sensitive to any changes that occur.